Hey there, and welcome to Concierge Medicine Radio, your source for actionable advice and real stories of physicians running and growing concierge practices. For more interviews and notes on today's show, please visit conciergemedicineradio.com and enter your email. Now, let's join your host, Taylor Pearson.
Hey there, and welcome back to another episode of Concierge Medicine Radio. I'm excited to bring you another interview today with Dr. Rob Lamberts, based out of Augusta, Georgia, about how he runs his direct primary care practice and some of the fundamental yet unexpected changes that have happened as a result of his transition. From an improvement in his day-to-day happiness, more time with patients, and better clinical outcomes, his transition into a DPC model has been all positive. In this show, we talk a little bit about why a desire to provide better care drove Rob to a DPC model, how Rob used the resources from his traditional practice to seed his new direct primary care practice, why he chose to go it alone instead of working with a consultant, how Rob structures his practice for a 1,000-person patient panel, and also some of the technology he's using, both Facebook to market his practice to patients in the local area, and the exact way he does that using his existing patients to get the word out, and the most valuable technology resources he's integrated into his practice to be able to provide better care. So without any further ado, let's get on with the show. Tell us a little bit about yourself, why you became a physician initially, and how you transitioned into concierge practice.
Well, I grew up in a family with a lot of education. My father is a PhD in physics. I have multiple siblings with doctorate degrees. And honestly, when I started in college, I actually was started as a music major. I always joke that the reason I chose a music major is because my dad wanted me to go into science. And so I obviously wanted to choose something contrary to what he said, and I like music. But deep down, I think I wanted to be a rock star or something like that. I was a voice major, but they were teaching me only to either sing in an opera or be a music teacher, and didn't find that interesting, and honestly felt like I didn't know what I wanted to do. I had no idea. And the more I thought about it, I ended up switching over to chemistry. And the more I thought about it, the more I felt like, my dealings with people and my dealings, I was good in interpersonal relationship stuff. I was good in dealing with other people. I like to be around people. And I was also really good at science. And so, the question is, how do I mix those two together? And despite the fact that I was kind of rebellious, I didn't like the pre-meds that I had met because they all seemed so interested in getting good grades and sometimes taking easier courses so that could have a higher GPA. And for me, I thought that was just kind of a sellout. But I decided, despite my feelings about pre-med, that I decided to go into, at least try and go into medicine. And so that's what I did. I ended up taking a couple of years off after college and just working just to make sure that it is what I wanted to do. And I ended up going to medical school. And as I went into medical school, I kind of figured that I would do pediatrics. Actually, I always liked pediatrics. I always liked kids. And I do think that as far as doctors are concerned, there's either those, you can divide doctors into two main categories, the ones that really like to take care of kids and the ones who absolutely detest taking care of kids. Doctors aren't split on that. But anyway, as I did my medical school stuff, I ended up really liking the problem-solving aspect of internal medicine. I thought it was really interesting, and I had very good rotations in it. In the end, I just thought, I want to go primary care. It's what I like doing, is taking care of people, all age groups. And so that's essentially how I ended up being a doctor. It just kind of fit what I liked and what I wanted to do.
So tell us a little bit about then how you transitioned into concierge.
I actually practiced for 18 years doing, I practiced for 18 years in the typical practice of primary care practice. doing insurance, and actually initially started out in a practice that was owned by the hospital, and we broke off and actually became pretty profitable, ran the practice, went pretty well. But as time went by, I got more and more frustrated with the fact that I was getting less and less time with my patients and more time devoted to making sure the right codes are put in, making sure that all the right information is put in so that I could justify the bill that I was doing. I just felt every day at the end of the day that I was leaving so much care on the table because most of my time wasn't devoted to care. It was to documentation and filling out forms and justifying the decisions I made.
Yeah, I think a lot of physicians feel that way. So what was it specifically that pushed you into concierge then, and how?
I had kind of a philosophical breakup with the other partners as my practice grew. And again, I think it was that I just didn't want to compromise, and I kept trying to make the care that I gave to be personal and to spend as much time with my patients as possible. And I actually did that using technology. One of the reasons we were successful using electronic medical records is I saw them as a tool to do the stuff that I don't like, the documenting and such, as rapid as possible, so I had still the maximum amount of time in the exam room with the patient. Well, my partners didn't like the fact that I kept changing things, and that I was a senior partner in the practice. And so when we had that philosophical breakup or a divorce, it basically is, I had to choose. Was I going to keep doing what I was going to be doing, or was I going to join another practice, go to the VA, do all these other things? And all of those models seem to be laden with the very thing that I absolutely hated about healthcare, which is dealing with the bureaucracy, dealing with the stressor of having to make sure I had all the codes, making sure that I met meaningful use criteria, blah, blah, blah. And I like the idea of concierge medicine. Yeah, the idea appealed to me from a simplicity standpoint, from a lifestyle standpoint. But the thing that I struggled with was the fact that, I enjoy taking care of my elderly patients. I enjoy taking care of the patients who don't have much money. And it was like, I just kind of felt like I really struggled with the idea of a regular concierge practice, where the price was set high, or the boutique type of practices, the VIP type of practices. And this is just me personally. I don't criticize people who do it. I understand 100%. But for me, I couldn't say, I just couldn't do that. And so actually, Dave Chase, who, founded Avado Healthcare, and which was subsequently bought by WebMD, he was reading some of the stuff that I was writing, and we started talking back and forth, and he kind of clued me in on direct primary care, which is just basically a lower cost model of that. And I started really thinking about it, and for me, it kind of seemed like the only kind of medicine that I wanted to practice was something that was still affordable for most of the people, and yet it was something that it did get out of that model of having to spend my time focusing on documentation and putting in codes. And so when I had to go somewhere, I had to do something. And so that was the model that I chose. And part of it was in my writing. I've been doing quite a bit of writing for my blog and for my, mainly for my blog about healthcare reform and stuff like that. And the more I thought about it, the more I felt like, if done properly, this model could do more than just offer an escape from doctors who want out of the rat race, who want to jump off the hamster wheel of healthcare. And it offered actually something that I believe now still, and I definitely believed at that point, that it could transform the system. And so, really transform the healthcare system if done right, because all of the motivations of care were, 180 degrees. I was actually taking care of the patient, not the insurers. And I was focused on offering better care, not more care. And that's the thing that really appeals to me. And that's the thing where I finally opted to say, this is the model that I want. I'm going to offer a monthly fee that is reasonable for people, but I also want to be able to, I don't want to have motivation to, the more things I do, the more I get from patients. I wanted to offer value and be able to make money with that through just running it efficiently and running it using technology to allow the system to run better. So, I mean, that's pretty much how I fell into what I'm doing right now.
Let's dig into the nuts and bolts of that then a little bit. So how did you go from your practice where you said you were the head to the concierge practice you're in now? What did that transition look like?
Well, and we kind of, worked on exactly how I was going to get out of the other practice or be shown the door of the practice, whatever perspective you want. But, they worked that buyout because I was a senior partner, because I had, a pretty substantial practice. And there were a total of 5 doctors in the practice at that point in time and two mid-levels. So it was a pretty big practice. And so they essentially bought me out of my side, which gave me some seed money and allowed me to contact all of my patients and say, hey, this is what I'm doing. I'm offering you this opportunity to follow me. And, I was fortunate that there was not opposition to me doing that. I think they realized that at the maximum, I was not going to take a huge number of patients with me, because this type of practice, in my old practice, I probably had between 3,000 and 4,000 total patients. And so it's hard to know exactly how many you have in that kind of a practice. But I knew that, at the busiest, if I could get up to 1,000 patients, that would be a lot. And so it's just a question of how do I transition. So I presented it to my patients.
When you say how you presented it, how did you do that? Like, I know some doctors will send out emails, or some will did you do it one-on-one? How did you kind of educate them on the transition?
I sent emails. I sent actually a brochure of my practice to all of the patients that I felt would be interested in it. About 1,000 people, brochures that I sent out to the new practice. And then I reserved a spot to give a talk and had about 300 people show up and listen to what I was saying about my new practice and how it would be different. And, I had no idea how many patients would choose to follow me and how many patients would come from the old practice. My estimates were high. And I figured I was one of those doctors who really tried to spend extra time with people. And I had very loyal patients who really were sad that I was changing. But again, I wasn't sure where to price it, and I didn't want to price it too high. But at the same token, I didn't want to price it too low and make it impossible for me to succeed. So,
well, how many patients did make the change with you then?
I would say out of my practice that I have now, which is now around 500 patients, it's very close to 500 patients after a little over a year. Actually, it's been a year and 4 months that I'm up to 500 patients. And I would say that probably maybe around 300 of those are from my old practice. So, a decent number. I definitely don't know if I could have ever survived without that base to get stuff through. But anyway, that's kind of where things stood as far as that goes. A lot of the other patients were attracted through various other means, word of mouth to some extent. People who say, oh, look what my doctor's doing. And then one of the local news channels ran a piece on me, and then another follow-up piece a few months later of what I was doing in this practice, and that got me quite a few new patients as well. I really haven't done that much marketing besides that. I tried to grow slowly enough that as I did this, I could continue to give the quality of care that I wanted to give, which is the main reason I switched. It wasn't a financial decision. It was a decision of conscience that I didn't feel like I could conscience giving the care that I was giving to patients. Just, again, felt like the system was forcing me to do a bad job, to make people wait and to give them subpar care. And so as I opened this up and we tried to figure out exactly how to run a practice like this, I've never focused on rapid growth. I focused on growing smart and growing well so that the care I give is as good a quality as I can give.
And how did you find out kind of about the nuts and bolts of making the transition? Did you have a consultant come in and help you? Was it something you called other doctors? How did you learn how to set up a concierge practice?
I did talk to a number of practices that had done it. I did talk to a bunch of other docs who had gone through this, and I talked to Dave Chase and some of the folks at Avado. I went to a AAPP meeting, and I got some ideas through there, and just sat and talked to people about how it was going to work and how I was going to do it. But I really kind of felt like my idea that was very much going to rely on the use of technology to streamline in the processes of care, not take place of personal care, but to supplement it and to make it better. That I didn't hear any consultants who really knew how to. I did know that we started an electronic health records back in 1996 in my old practice. I was one of I had given talks in front of the CDC for the grand rounds of the CDC. I had given talks for HIMSS on, ambulatory medical records. I was the president of our EMR's user group. So, I felt like there wasn't many people who understood applied technology better than I did. I think some of it is the internist brain that works very much like a computer programmer's brain in some ways, always trying to solve problems and do things in an efficient way. And so, I was very hesitant to spend my money on a consultant I was very suspicious. Maybe some of that's just the hubris of being a doctor, that we think we know everything, but which is, I'm sure that's part of it.
Tell us then how your practice is set up, what your kind of business model is. You mentioned the subscription model, and then a little bit about the role technology plays in that. So I guess what is a good way to start maybe, what does one of your typical days look like? And then you can go on from that to a little bit about your business model.
One of my typical days is it's lightly scheduled. If I have more than 5 or 6 appointments scheduled, in fact, if I had more than 3 appointments scheduled, a lot of times that's heavy. 3 is, for a long time, I would have some days where I had no appointments scheduled. But that doesn't mean I wasn't offering care. I have a secure messaging tool where patients would send me, messages about what their symptoms are and what's going on. I would talk to people on the phone. I would kind of handle problems in whatever way I could, using whether it's the telephone or, if people needed to be seen, they can come in for the brief problems. New patients always, or new families, I guess, but if I hadn't seen somebody before, I would not give them care unless they came in and established as a patient in person. And so those visits, oftentimes, I usually schedule an hour for those visits. Just a lot of it is to discuss exactly how I offer care and how it's different, because it really is a paradigm shift, not only for the doctor, but for the patient. Patients really aren't ready or used to the idea of the availability that I've got. And the idea is that so the business model for me is monthly subscription ranging between $30 and $60, depending on the age of the person. I do have a registration fee as well, just to kind of give me a little upfront money, and also because of the little bit extra work of setting up people's charts and that kind of thing.
And how much is the registration fee?
$50 per person. And so, again, it's a lower cost than a lot of the concierge practices do, but it's in line with what the Q-Lions and those types of practices in terms of the monthly fees. And for me, the idea is that if I'm being paid on a monthly basis by the patient, and I don't charge extra for office visits or phone calls or consultations, I don't accept walk-in visits because it goes against the philosophy, which says, I believe that the reason that office visits are viewed as the model of care that we give. It's the care transaction that happens in the United States healthcare system is you have to see the doctor. And I really believe the reason for that is because of the payment system, which says, first off, I don't get paid unless I see the patient in the regular payment system anyway. But it's this wedding between problem codes or ICD codes and procedure codes or CPT or E&M codes. And that's what I get paid to do as a doctor in the United States, is to match problem codes, ICDs, with CPTs. And if I do that, I get paid as long as I document both the problem and the procedure. And that has to be done in an office visit. But it's not really it's not the most efficient way of caring for a problem. In fact, the idea that we care about problems at all is, to me, a fallacy. That really, you want to avoid problems. If it's a patient, you want to avoid going to the doctor's office. You want to avoid going to the emergency room. You want to handle the back pain before it becomes serious. You want to be able to manage the diabetes in such a way that it doesn't result in the admission to the hospital or, the complications of the disease. That's kind of the way that I've approached it, is that, my goal is not to have a full office. In fact, ideally, my motivation is to keep my patients healthy, to keep my patients happy, and to keep them paying their monthly payment. And if they are content with the care that I'm giving, so that means that I'm focused on customer service, that when they do need to be seen, they can be seen immediately and don't have to wait. And that if I can go after problems before they get big, which means going after people who aren't in the office and trying to bring them in, or at least make sure that their care is good, that they're doing well, allow communication to happen over whatever means it needs to. You can go back and forth with people about problems, and I don't have to create a office note that looks like a typical doctor's note, because I don't have to bill from that anymore. I'm just documenting for the sake of care, and that's it's hard to describe just how different that is. It is nearly the life of a typical doctor is so caught up in the documentation game, and so much of what we document has nothing to do. In fact, it interferes with good care of the patient, that when I was freed from that, it took me a while to really figure out how I would document in the first place.
So how do you document it?
That's probably the hardest thing that I personally face, because of my, whether it's ambition or delusion, whatever you want to call it. I really wanted something that matched it. And so I looked at a bunch of EMR systems out there. I really tried to find something that would manage the workflow of my office well. And everything was a huge compromise. And it was a huge compromise that I'd still have to spend a bunch of money for, because most EMR systems, in fact, pretty much all EMR systems, are essentially built for the sake of billing. They're not built for really good records. And so I ended up very reluctantly. I went for the first 3 to 4 months of my practice trying to fit the square peg in the round hole, and then finally decided there was no good medical record system out there that worked for my kind of practice, what I really wanted, and certainly not towards what I envisioned in the future. And so I built my own. I basically learned how to write in a database and put together a patient database, and within a month had something that worked better than any EMR system that I had been using. And since that time, about a year ago, I have been trying to improve on and really work on the system that I have right now, which is based on FileMaker Pro database. And that's how I document, is within there. But the office notes, again, are set up differently. They're not really meant to fulfill E&M coding requirements, which they're not at all. They're just meant to convey information and to store information in a way that's useful. And that was really hard. That has been by far the thing that I've spent the most personal time on, and it would have been a whole lot easier if I hadn't been so stubborn and I had just compromised and gone with a regular EMR system. But yeah, that was my choice, and I think it's paying off, but it's going to be slow still to pay off in the big picture.
Well, let me go back then. You mentioned you've been slow to grow, but what marketing channels have you found to be effective? How are people finding you and coming to your practice? Do you offer a free consultation, or what does that look like?
First off, certainly having a good website is essential. There's no way that patients can find out about what you're doing. And the fact that I was writing as much as I do, there's a lot of my writing out there, and a lot of the new patients have come in and they've already learned my philosophy because of what I've put out there on the web. I've blogged for the past 8-9 years. I think I've had a medical blog, and with a fairly high visibility on the internet overall. But actually, it's interesting because I think the number one tool for me for reaching out to new patients has been Facebook. I didn't at all think this was going to happen, but I had a Facebook page and have all of my patients have signed up for it. Not all of them, but a lot of them have. And I'll interact with people there and talk about, when we're closing, or I'll write some humor there or give some advice about the allergy season or that type of stuff. And a lot of what I write gets shared, people share with their friends, and they'll share, it'll just kind of go, it has gone viral. And the nice thing about Facebook is that if you have, I've got about 1,700 followers on or 1,500, I forget exactly how much, but followers on the Facebook page. But if I use the promoting of a post on the Facebook page, then it will go to the people who are friends of the people who are following, which is a local audience. It's exactly the audience I want to reach to. The decision makers tend to be female more than male in the circumstance, and as far as healthcare decisions go. And more females tend to be on Facebook as well. So, again, it's actually, I'd say I've gotten huge bang for my buck. It's very cheap to promote a post on Facebook. Costs you $20 to $50 depending on how much you want to spend, but that's nothing for marketing.
Interesting. Yes, you're using Facebook promoted posts to promote posts to your existing patients, and then that's getting pushed out to all their friends on Facebook, which is, as you said, everyone in the geographical area that would be interested.
And demographics, because they're going to be in the same demographic group as my patients as well. So that automatically chooses.
Well, what is the typical demographic or typical patient profile for your patients?
Average, probably somebody in their 40s, between 30s and 40s are my average patient age. And I would say I'm maybe 60-40 insured to uninsured. So a good segment of uninsured patients for sure. But most of them are not wealthy. I don't have a lot of wealthy patients. It's usually middle class, work people with jobs. I have some Medicaid patients, and I have probably about 15% of my patients are still Medicare patients who have opted to pay extra for what I do.
And do you offer any special or unique services to attract patients, like special hours, seminars, or is it primarily just word of mouth and Facebook?
The thing that my patients seem the most thrilled about that most of the people, the word of mouth, that is via the fact that I'm accessible. The fact that it's not hard to reach me. It's not hard to, if people have a problem, they can send me an electronic message and I'll respond right away. Or they they'll call the office and I'll talk to them about it. The lack of hassle, patients are just bragging about that. And so I have not focused on special services. I know a lot of offices say, well, we'll do a 2-hour consultation and as if spending 2 hours in the doctor's office was a positive thing. If my dentist gave me a 2-hour dental appointment, I would probably avoid it and not want to go to that dentist. And so, for me, the concept of just availability and common sense and the fact that I really want you to be well, I really want you to be healthy. I'm offering labs I do pass-through billing for labs, and so I can charge $4 for a CBC, and I can we can go after the cheapest medications that I'm finding ways to offer just customer service that people just aren't used to. And that's really, I think, the value. What you're trying to do is offer them value and make it so that their monthly payment doesn't seem like all that much. And actually, that's not all that hard.
So once people hear about you and they hear kind of a little bit about how your practice works, as you said, cheaper labs and medications, what happens next? Do they just kind of walk up to the front door and join, or how does that process work?
A good amount of the phone calls and a good amount are on the internet. They go to the website and go sign up through there. And we send them all the information and educate them on that. And then, we've actually now, the patients will register and, they pay their registration fee. And then at the first visit is when they pay their monthly payment. They start paying their monthly payment. And so, that's kind of the way that it's worked out as of now, that the patient will contact us and we'll gather their information back and forth, either with emails or with, we'll mail them a packet or hand them a packet if they happen to walk in. But the majority of people are not walk-in visits. They're actually their visits. The majority of people will reach us either through the phone or through the internet. And I'd say it's probably maybe 30% on the phone and 70% through the internet.
What are your most trusted resources? If you're trying to figure something out in your practice, you don't know what to do, where do you go look for that?
Up to date. There's no question as far as, as far as medical resources, looking at those types of things, up to date is far second to none. It's just terrific. I do some Google searches and I do some, stuff on WebMD or Mayo Clinic, but typically that's more for patient handouts because that's not really geared towards physicians as much. As far as resources, as far as running the practice and things to do, honestly, my main resources are the other doctors who are doing it, and we're starting to develop a little community where we're communicating back and forth with each other about, this is what I'm doing, and just as far as those types of things. I use Hippocrates for medications. I always be going to goodrx.com for finding the cheapest drug prices for people, and people don't realize just how much of a difference in drug prices you can have from one pharmacy to another, but I've saved people hundreds of dollars per month on prescriptions just by doing smart shopping for their drugs, which, again, the minute they see those types of savings, then they're already loyal patients. And so those are the main resources that I use, trying to think if there's any other.
As far as talking with other physicians, is that just informal? Like you give them a call on the phone or shoot them an email?
Usually it's a quick Twitter message, and then we go into an email where we talk about stuff. But, I do sometimes the local doctors, I'll consult with them and try and contact them and do a curbside consult on some of the stuff that we're doing. But most docs the local consultants are so caught up in the day-to-day hamster wheel that they don't really have time to stop and talk about patients.
Looking back kind of on your transition and the last year and a half as you've been running your new practice, is there anything you would have done differently? Or if you were talking to a physician about to make the same transition, what advice would you give them?
Yeah, that's hard to say because the decision for me to build my own electronic record was by far the costliest decision. It slowed me down a lot. It slowed my growth down a lot because I spent so much of my energy toward doing that. But do I regret it? I haven't seen any alternative that could do the things that I'm trying to do. And so in that sense, I don't regret it. I just wish technology was not so closely right now tied to the billing system and the billing of medicine and just the sick healthcare system we've got. But I would say that I would advise docs to be very cautious in their approach, that it's easy to get optimistic and it's easy to kind of say, oh, yeah, this should be no problem. And getting out there and doing it is a whole different thing. And it's still such a young market. In other words, there's still a wide variance of models of what people are trying to do. A lot of folks are still focused a lot on walk-in visits or focused on the office visit model. I will say that the number one thing that patients want right now that it's not even close, the number one thing that I win people's loyalty on is accessibility. They want to not feel like the doctor is saying stay away. They want to, and so the more you can make yourself accessible to your patients, and my fear was that if I made myself accessible, then they would utilize my services like crazy. People are saying, well, if you don't charge copays for visits, they're going to just come in all the time. And, I'm sorry, but it takes a pretty sick mind to feel like coming into the doctor's office frequently is a good thing. I mean, it really, and I can see why people would do it, every 2 weeks or every once a month, but that's not going to break my bank, or, that some people are going to send me a lot of messages and wonder about this and that. But the fact is that I've found that by making myself more accessible, that actually has allowed my patients to become more independent and more confident of their own medical care, that they know the right things to do. And they know that if they don't know the right things to do, that they can reach me. And, I've approached this from the very start as making it be as non-doctor feeling as possible, that I am simply a resource for their own medical care. I am not, I'm not trying to say, all care has to go. And I think that's the unwritten message that we send to our patients when we make the office visit be the be-all and end-all of all things, that I'm not going to give you any care unless you show up in my office and I give you that care. And, if all I'm doing is giving them advice on secure messaging, or if all I'm doing is sending them a handout on sinus infections on how to handle it, or, those types of things, it means way more to my patients that I'm saying, no, it's your care of yourself, and I'm giving you the resource to be able to do that. And it's an entirely different message than they're hearing from the system. And that's the message I think that's going to resonate the most with people in the big picture, that they don't feel alienated anymore, and they don't feel unsafe. They feel like if they need me, they've got me. And, so far at 500 patients and only 2 nurses, all I've got on my staff right now is just me and 2 nurses, and we're handling it pretty well and still growing. We've got about a 1 month waiting period, or a few weeks now, where if people are wanting to schedule with a new patient, I'm pretty booked out as far as new patients go.
What exactly do you do to make yourself accessible? Are your patients text messaging you, or how exactly does that work? Are there any tools you're using?
Yeah, and one of the main tools I use is something called Twistle, which just came out of beta, actually, and Twistle, Twistle, and it's a secure messaging app that allows patients to kind of send me text messagey type of things. They're not specifically text messages because they're secure, and you can involve multiple people in a conversation. It's a kind of a threaded conversation, but it's more conversational. And I can also send send files, but it's HIPAA compliant, it's secure, and patients love that tool. They just love that tool. I also, if patients call after hours, they'll leave a message, and it will send me a text message immediately, and I'll listen to it. And if it merits calling them back, I'll call them back right then. During the daytime, we try not to send people to voicemail if we can help it. We try and answer everybody's phone calls and answer anybody's questions. And, I'll answer the phone if my nurses are busy. And if I'm not doing other stuff, I'll handle problems on the phone. And sometimes that can really shorten the process because it doesn't go through that. Talk to the nurse, you hang up, the nurse talks to the doctor talks to the nurse, and then the nurse talks to you, and then you have another question. And it just takes so long to solve problems, whereas I can just sit and talk to the patient and handle the problem in about a quarter of the time. So the more of that kind of stuff I can do, the better.
And that's all through Twistle?
Well, that's either through Twistle or through phone calls.
Okay.
Yeah, Twistle's a good app to do it with. Some patients want to email me, and I'm okay with that. It's not as secure. I don't like sending secure medical information that way, but you can get people to sign a HIPAA waiver, and they're okay with you doing it that way.
And is Twistle a mobile app? Is it they send it to you from their smartphone?
It does both mobile, and it's a website. You can do it on as a web app, and you can do it as a mobile app. So they just came out with an Android app, and they've had an iOS app for a while. So that's the cool thing. I do firmly believe in the big picture. One of my big goals down the road, once I've become profitable enough to be able to not have to worry about my salary, which is, I'm still really focused on that at the moment because I got to pay bills at home. But once I've kind of got all that, one of my main focuses is going to be on creating an open medical record where my patients can actually have access to all of their test results, and that they will be able to have access to their charts essentially and actually collaborate on their charts. It's one of the dreams of mine in the big picture is this idea of the collaborative medical record that really it should be owned by the patient, not by the doctor. It's owned by the doctors usually because it's based on billing and stuff. But if it's truly just based on having accurate and good medical information, the vast majority of the information that goes in the record doesn't have to be hidden from the patient. Very few times do I write something that I'm contemplating something about the patient that I don't want them to know about. Most of the time, it's just putting in accurate, making sure it's accurate. And who better to make sure it's accurate than the patient themselves?
Are you familiar with Wellness FX?
I've heard of it. I'm not real familiar with it.
I haven't used the service. The business services, they do blood draws, and then they'll upload your information to their database, and they give you like charts and graphs that let you track how your biomarkers are changing over time. But you can just go, what I'll do is when I get blood work done, I just go in there and manually upload the data. And so it's obviously not as good as having a doctor or an expert come in and add their opinion and insight, but you can see over time how your biomarkers are changing, if things are getting better or worse.
See, now, here's the thing, though, and this probably is the biggest change in my care. I've always been the kind of doctor who, when in doubt, I don't order a test. If I don't really have a good reason to order, I am not a routine lab test guy. I just accept, because the real question patients have, and this actually, I alluded to it earlier, of how has my care changed. The biggest way it's changed is the emphasis of problems and procedures, which is, again, we order lab tests to find out stuff. We diagnose people with problems, and we have a list of problems that the people have and all this other stuff. And, for me, instead of that, I think it's far better to say, okay, what do people really wonder? Well, first off, they want to live as long as possible. So it's about risk. What is the risk, the person's risk? And what can we do intervention-wise to reduce that risk? And the second other important issue is what is their quality of life? So when somebody comes in with chest pain and they're worried about their chest pain, the first thing they often worry about is my heart. Is it my lungs? Is it something bad? And the second thing, we can say, oh, no, it's nothing bad. Don't worry about it. Well, then the second thing is they want to feel better. And I think docs oftentimes forget that. They just say, okay, well, good, we ruled out that stuff. And the patient's still hurt. And so what I'm trying to do is say, let's do tests only if that test gives me information that will identify risk, and it's been shown to identify risk. Or even if it does identify risk, but there's nothing I can do about it, then it's kind of worthless to do that kind of stuff as well. Some of the, real expensive cholesterol testing, most folks who do evidence-based medicine will tell you there's no evidence whatsoever tests offer any benefit aside from knowing, okay, so your LP, whatever, your VAC testing showed that your small particles and large particles are this and that. Well, have there been studies that show that an intervention can improve that? Well, yeah, lose weight and exercise. Well, I could tell them that without ordering a $200 test. And, so many times we're substituting markers and doing all these routine blood work for sitting and listening to the patient and understanding what is affecting them on a day-to-day basis and what are their risk factors. I mean, cholesterol is not.
So kind of the big picture from what I'm hearing is that because the incentives have changed in your model, there's no reason for you to go order these tests unless you feel like it's going to make them feel better and then they're going to stick around your practice.
Make them feel better or make them live longer. And, there are some times where, from a business standpoint, people, I want an executive profile. And I explain to them that there really isn't any good reason to order an executive profile every year. And we have long discussions about PSA testing of whether that's appropriate, really, for men. And it still is, but it's a pretty lousy test still. And I believe that there's going to be things in genetics that allow us do a whole lot better as far as screening tests go. But the idea is to say, how can I minimize my risk? And that my doctor is looking out for me to make sure that my risk is as low as possible. Not that I've had the right blood test done, but that I'm not a problem waiting to happen. And also that I feel good. And beyond that is that I'm just trying, one of the quality of life issues is that if you're spending $200 on meds and you can save, 50% of that by just eliminating meds you don't need or finding cheaper alternatives that are just as effective, then the quality of life of having extra money is not a bad thing. And patients really respond to that when they understand that I'm listening to them and I'm not ordering and putting them on meds without explaining how it affects their risk and how it will impact their quality of life. Either way.
So my last question for you then, Dr. Lamberts, is if you could only say one thing to physicians either considering the move into concierge practice or kind of already in that process, what would you say?
It's about the patients from my standpoint is the more you can focus on the past. I like to say that you're employed by the person who pays you. And in the old system, I was paid by insurance companies, and they were my employers, really. They were the people who I did the most work for. I made sure all the stuff was right, all the notes were right, that I submitted the right codes, and I spent the vast majority of my time devoted to making them happy enough that they'll pay me. And the patient was just the raw materials that will run through that machine to generate notes. And that sounds crass, but that's the reality of healthcare. Patients are raw materials. They are not the object of healthcare. They are the raw materials for the healthcare transaction, which is between the doctor and the payer. And that's sad, and that's why it's so expensive, is because patients are not, they're just what we use to get paid. In this case, it's about the patient. I'm being paid by the patient. And so suddenly my focus is entirely on what's best for them. Now, does that mean that I'm going to bend over backwards and sacrifice my life for this sake? No, heck no. You gotta run a business so that you can be profitable. But I really do believe that patients are so hungry for that. I've had extremely low attrition rate from my practice, and just keep adding new patients, and keep having phone calls every day, several each day, for wanting to become a patient. And people just respond to being treated like people and not a commodity. And so, my advice is when you're doing this, look at it from the standpoint of the person who's sitting across from you in the exam room. And I believe that in doing that, you're tapping into a revenue source that is huge. If you run it well, I just think the sky's the limit for this type of practice. My eventual goal is, if I get up to 1,000 patients, I'll earn way more money than I was earning in my old practice. And I can be doing that, be having happier patients, having a much better quality of life myself, and saving the system money, which is kind of like too good to be true. But if it runs well, and that's still a big if, because it's a hard thing to do, especially without the proper tools in place. But it's got to always be about the patient. It's got to always be about the people who healthcare is really about. And that's the joy, and the day-to-day joy of this kind of practice for both me and my nurses, is the fact that our patients are just so happy with what we're doing. They're just so delighted in what we're doing. And we are too. It's just so much easier to go into work each day. So, it could be a little early for people to make the jump because it's still developing. I think there's still a little bit of that I'm one of the pioneers still, even though it's getting more and more common, that we're still kind of toward the cutting edge. But I think as it gets more mainline, it's gonna do everybody well if it's done well, and if it's focused on what's best for the patient. So that's my advice: is make it about the patient.
Absolutely. Well, thank you very much, Dr. Lamberts. If people want to get in touch with you, where's the best place to find you online?
My Facebook page, my web page, and honestly, people just email me at rob@drlamberts.org, and that's Dr. Lamberts spelled all out, DOCTORLAMBERTS. Don't forget the SDN.org. And if people want to reach me, they can reach me that way as well.
Well, thank you very much, Dr. Lamberts. We appreciate your time.
No problem.
You can go to conciergemedicineradio.com to get this episode's notes and links to everything we've talked about, as well as the entire back catalog. For those of you working on bringing in new patients or retaining existing patients in your direct pay or concierge practices, we've also got a new report on the 5 keys to marketing for direct pay and concierge physicians. After asking physicians across the country about their biggest problem, I kept hearing the same thing come up. Patient education and marketing. How do we help patients understand what we do? So I put this report together after interviewing dozens of the most successful concierge and direct pay physicians across the country for the stories and tactics on how they've been able to generate dozens of word-of-mouth referrals each month, find more new patients through speaking opportunities, get featured in their local press, and use their website and online presence to educate their patients and grow their practice. So if you'd like to read their stories and see how to use them to help grow and retain more patients in your practice, you can download that on our site. Talk to you next Tuesday morning.
Thanks for joining us today at Concierge Medicine Radio. If you found today's show valuable, we'd love it if you spread the word by leaving us a review on iTunes or sharing it with your friends. To see notes on today's show, please visit us at conciergemedicineradio.com. While you're there, leave us your email to hear about all upcoming episodes.